Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Nosiba, and with me is my partner for today's episode, Sara.
Assalamu alaikum, everyone. I know today's topic might sound a bit intense, but don't worry. We'll break everything down and slowly walk you through it. So by the end of the session, it'll all make sense.
Today we're talking about myeloproliferative disorders. By the end of this episode, you should feel comfortable with the big picture and with four specific diseases: chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, and essential thrombocythemia. The way this will work is for each disease, we'll walk through the pathology first, then the clinical presentation, then the diagnosis, before we finally discuss treatment, just like in the real world. Before we go into detail for each of the diseases, let's start with an introduction to myeloproliferative disorders in general. Sara, what do we mean when we say myeloproliferative disorder?
So, myeloproliferative disorders are clonal disorders of the hematopoietic stem cell that cause overproduction of one or more myeloid lineages. The cells are usually mature and functional. The only issue is that there are too many of them. Depending on the specific disorder, you can see either too many white cells, too many red cells, or too many platelets, and you often get things like splenomegaly and a very active bone marrow.
All right, let me just get this straight. The key idea is there's one abnormal clone at the stem cell level, and then that clone produces a ton of mature cells, right?
Yeah, exactly.
So now that we have an overview of myeloproliferative disorders, the next step is to break them down into groups. Let's classify them in a way that actually sticks, something that makes sense in your head and connects back to the underlying causes.
The simplest way is to start with one main genetic question. Is BCR-ABL present or not? If BCR-ABL is present, which is also called the Philadelphia chromosome, that points to chronic myeloid leukemia, or CML. If BCR-ABL is negative, then we start thinking about the other myeloproliferative disorders, which often have mutations in JAK2, CALR, or MPL. These are polycythemia vera, primary myelofibrosis, or essential thrombocythemia. So, CML is the classic BCR-ABL disease. The others are usually in the JAK2, CALR, and MPL family.
All right, so we can split them into two categories: BCR-ABL positive and BCR-ABL negative. But before we go any further, quick question. Do these disorders ever overlap clinically?
They do. The BCR-ABL negative group can share similar features, and sometimes one condition can evolve into another over time. For example, polycythemia vera or essential thrombocythemia can later progress to secondary myelofibrosis, and any of them can eventually progress to acute leukemia in a subset of patients.
With that said, it's time for a quick quiz. Let's see if everything we've talked about so far is sinking in. Okay, Sara, ask me something.
You got it. Okay, if you find a BCR-ABL fusion in a patient with a myeloproliferative picture, which diagnosis are you strongly thinking about?
That would be chronic myeloid leukemia, right?
Yep, it's chronic myeloid leukemia. If that popped into your head, you're right on track.
Since CML is a classic BCR-ABL positive disorder, it makes sense to kick things off right there. So let's break it down. What's CML and how does it happen?
Sure. CML is one of our four myeloproliferative neoplastic disorders, where cells from the myeloid line are the ones that are out of control. The underlying problem is a translocation between chromosome 9 and 22, written as T922. This creates the Philadelphia chromosome, which carries the fusion gene. The BCR-ABL protein is a constitutively active tyrosine kinase, so the signaling pathway that tells myeloid cells to grow is permanently switched on. As a result, you get a huge increase in mature and maturing granulocytes.
So what you're saying is CML is caused by genetic rearrangements that makes an overactive tyrosine kinase, and that makes myeloid proliferation go crazy.
Yeah, way to put it.
Okay, how about the clinical presentation? Say a patient came in with CML. How would you expect them to present?
Oftentimes, patients are middle-aged. They'll show up with common features like fatigue, weight loss, night sweats, and a feeling of fullness or discomfort in the left upper abdomen due to splenomegaly. Sometimes symptoms of hyperuricemia like gout are there due to high cell turnover. Some patients are even discovered incidentally on a routine CBC that shows a very high white cell count.
So to sum it up, a typical CML patient would come in with pretty nonspecific symptoms like fatigue, weight loss, night sweats, plus an enlarged spleen. Now, the big question is once we suspect CML, how do we actually confirm it? Let's move on to the diagnosis.
We'll discuss four main diagnostic tools today. They are CBC and blood smear, cytogenetic studies, molecular testing, and the leukocyte alkaline phosphatase, or ALP score. Starting off with the CBC, it'll show significant leukocytosis, which is an elevated white cell count, as well as basophilia, which is normally a really rare finding. Also, for the blood smear, we spot the full spectrum of myeloid cells, from blasts to mature neutrophils. Second, cytogenetic studies. Karyotyping will show us the Philadelphia chromosome, or the T922 translocation. Third, molecular testing. We'd use techniques like FISH or PCR to detect and quantify the BCR-ABL fusion. This is important not only for diagnosis, but also for monitoring the disease over time. Last, we'd be looking at the leukocyte alkaline phosphatase, the ALP or LAP score. In CML, the LAP score is low, which can help distinguish it from a reactive leukocytosis, where the LAP score is usually normal or high.
So, just to summarize, for CML, the key combination is very high white cells, presence of the BCR ABL fusion, and a low LAP score.
Yep, you ate that.
So, that's how we confirm the diagnosis. But getting the diagnosis is only the first step. Once we know it's CML, the next thing we need to figure out is what phase is the patient in. So, let's break down the three phases of CML.
Yes, CML typically progresses through three phases. The first phase is the chronic phase, which is where we'll find most patients. Blast cells are less than 2% of blood or marrow cells. Symptoms are often relatively mild or slowly progressive. The second phase is our accelerated phase, which is where treatment will fail. Here, we'll see worsening blood counts and symptoms, and we'll also see increasing blasts, but not yet at an acute leukemia level. Third is the blast phase, or the blast crisis. This is where blast cells make up a large proportion of the cells, usually over 20%, and here it'll behave like an acute leukemia. Ideally, treatment aims to keep the disease in the chronic phase and prevent progression.
Okay, we know all about the etiology, clinical presentation, diagnosis, and stages of CML now. But how do we actually treat it? And what do we look for in the response to treatments?
Good question. Treatment and response in CML revolve around first targeting the BCR-ABL protein and then checking for remission. So, for treatment, we're looking at tyrosine kinase inhibitors primarily, or TKIs, because they directly inhibit the BCR-ABL, which is a tyrosine kinase. Other options can include cytoreductive drugs and, in selected patients, stem cell transplantation, but TKIs are the central strategy. Now, for the response assessment, which is done at three main levels. First, the hematologic response, which will show normalization of blood counts and disappearance of symptoms like splenomegaly. The second is cytogenetic response. Here, we'll see a reduction or disappearance of the Philadelphia chromosome on karyotyping. And finally, the molecular response, where we'll see a decrease in BCR-ABL transcript levels on PCR.
So, in other words, as treatment works, you expect the white count to come down, the Philadelphia chromosome to disappear, and the BCR-ABL levels to drop significantly. And that brings us to the end of our segment on CML.
I hope you were paying attention, Nosiba, because it's time for another quiz. Okay, here it goes. In CML, what happens to the leukocyte alkaline phosphatase score?
It is typically low in CML. It's what differentiates CML from reactive leukocytosis, where you'd expect to see a normal or high LAP score.
Bang on. Dab on them, Nosiba.
Okay, so CML was all about an elevated white cell count. Now let's switch gears and talk about a disease where red cell count is elevated instead. Sara, can you introduce Polycythemia Vera to us?
Absolutely. Polycythemia Vera is our second primary myeloproliferative disorder, characterized by an increase in red blood cell mass due to a clonal stem cell abnormality. It falls under the umbrella of absolute polycythemia. We can think about polycythemia in three broad groups. The first is absolute primary polycythemia. That is polycythemia vera, where the bone marrow itself is the problem. It's associated with a JAK2 mutation, which makes the cells more sensitive to growth signals. The second is absolute secondary polycythemia. Here, red cells are increased because of increased erythropoietin from things like chronic hypoxia or certain tumors, not from the bone marrow. Third, apparent or relative polycythemia. Here, the red cell mass is normal, but plasma volume is reduced, making it seem like red blood cell mass is increased, for example, in dehydration. For our case of primary polycythemia vera, The red cells are proliferating even when erythropoietin levels are low.
Okay, that makes sense. So, Polycythemia vera is the primary JAK2 driven disorder. Secondary and apparent polycythemia are due to outside factors or changes in plasma volume. Now that we understand the pathology behind polycythemia vera, let's discuss the clinical presentation. What does a typical patient with PV look like?
A typical presentation might look something like this: plethoric or reddish complexion, visual disturbances or a sense of heaviness in the head because of the high blood viscosity, pruritus or itchiness, especially after a warm bath or shower, splenomegaly, as we see with the rest of our disorders, headaches and dizziness, and sometimes symptoms related to thrombosis, like pain or swelling due to clots. Finally, once again, we'll see features of hyperuricemia, such as gout, because of increased cell turnover.
So, if you see someone flushed, itchy after showers, with high hemoglobin and a large spleen, polycythemia vera should be at the top of your list of differentials. Okay, we know how a patient with polycythemia vera would present clinically, but how can we confirm this diagnosis?
Diagnosis will be based on CBC in serum, molecular testing, and bone marrow biopsy. For CBC, we'll see a raised hemoglobin or hematocrit, indicating increased red cell mass. For the serum, we'll see low erythropoietin levels, which helps distinguish PV from secondary polycythemia, where EPO is usually high. For molecular testing, we'll see the presence of a JAK2 mutation. For biopsy, we'll see a hypercellular bone marrow with prominent erythroid proliferation. Finally, it's important to keep in mind that to confirm the diagnosis of primary PV, we'd need to eliminate all other causes.
That makes sense, because now we have a structured way to think about it. A high hemoglobin and hematocrit, JAK2 mutation, and low erythropoietin all point towards polycythemia vera. Okay, we've diagnosed our patients. Now the next step is to look out for possible complications.
Yeah, I got you. I'll mention 3 key complications. The first is thrombotic events, where deep vein thrombosis, stroke, or hepatic vein thrombosis, which is also called Budd-Chiari syndrome, can be present. The second is bleeding, because while platelets are numerous, they're functionally abnormal. And finally, gout and renal issues, due to hyperuricemia from the increased number of cells breaking down. And, as we mentioned earlier, PV can progress into 2 other pathologies. First, secondary myelofibrosis, or the so-called spent phase, where the marrow becomes fibrotic, and second, progression to acute leukemia.
So the key complications are thrombosis, bleeding, gout, and progression to secondary myelofibrosis or acute leukemia, right?
Yep, perfect.
Wow. With all these scary complications, PV is definitely not a condition you can ignore. The good news is we can do something about it. So let's shift gears and talk about treatment options.
The main treatment goals here are to reduce the red cell mass and to prevent thrombosis. There are 4 ways we can do this. The first is phlebotomy or venesection, which is the repeated removal of blood to keep hemoglobin and hematocrit under control. The second is low-dose aspirin. And third, cytoreductive therapy. Drugs such as hydroxyurea are used in high-risk patients to reduce cell production through the inhibition of the ribonucleotide reductase enzyme, which is essential in DNA synthesis. Fourth, targeted agents. In certain cases, JAK2 inhibitors can be used. Management is individualized based on age, risk of thrombosis, and other comorbidities.
So, in summary, you'd remove some blood from the patient, give aspirin, hydroxyurea, and JAK2 inhibitors to stop the bone marrow from going crazy. And that brings us to an end on our segment on polycythemia vera. Sara, do you know what time it is?
Yep, it's quiz time. Here it goes. Which combination best suggests polycythemia vera? A. High hemoglobin, high erythropoietin, no mutation. B. High hemoglobin, low erythropoietin, and a JAK2 mutation present. C. Normal hemoglobin, low erythropoietin. And D. High hemoglobin from severe dehydration only.
I'm going to say B. High hemoglobin, low erythropoietin, and a JAK2 mutation present.
Exactly.
The third condition we're going to talk about is primary myelofibrosis. Myelo means bone marrow, and fibrosis basically means excess connective tissue. So I'm going to go out on a limb here and guess primary myelofibrosis is a condition where there's too much connective tissue in the bone marrow, right?
Bang on. Primary myelofibrosis is a myeloproliferative disorder where an abnormal clone of stem cells leads to the excessive fibrosis of the bone marrow, just like you said. The key concept here is that the fibrosis is driven by growth factors released from abnormal megakaryocytes, such as platelet-derived growth factor or TGF beta. These signals stimulate fibroblasts in the marrow to lay down collagen and reticulin. As the marrow becomes fibrotic, normal blood cell production is impaired. This is when the body shifts hematopoiesis to other sites, especially the spleen and liver. This will lead to massive splenomegaly.
So, because the bone marrow is fibrosed, the environment becomes inhospitable, and the body starts making blood cells elsewhere.
You're good at this summarizing thing.
So, now that we get what's going on in the bone marrow, all that fibrosis pushing out normal blood cell production, the next step is recognizing how this actually looks like in a real patient. Sara, walk us through it. How does primary myelofibrosis typically present?
You got it. Patients will often have fatigue and pallor due to the anemia, massive splenomegaly causing abdominal discomfort and early satiety, weight loss and night sweats as more general symptoms, and features of pancytopenia such as infections and bleeding.
The big signs and symptoms to keep in mind are fatigue, pallor, a really enlarged spleen, weight loss, night sweats, recurrent infections, and a tendency to bleed. Okay, let's say a patient walks in with the typical presentation of primary myelofibrosis. What tests would I order to confirm the diagnosis?
With this disease, we're looking at CBC in blood film, bone marrow aspirate, and a trephine bone marrow biopsy. First, for the CBC in blood film, we'll see anemia, variable white cell and platelet counts, and the teardrop cells alongside nucleated red blood cells with immature forms. The second is a bone marrow aspirate. It'll often give a dry tap because the marrow is fibrotic and difficult to aspirate. And third is a bone marrow biopsy, or the trephine biopsy. This is the key step. It shows increased reticulin and collagen fibers, confirming marrow fibrosis. Also, with molecular tests, it'll detect mutations like JAK2 or others, but BCR-ABL is always absent. Putting this together with the clinical picture gives the diagnosis of primary myelofibrosis.
So, in short, we diagnose primary myelofibrosis if we find teardrop cells on CBC and blood film, a dry tap from bone marrow aspiration, increased reticulin and collagen fibers from a bone marrow biopsy, and a JAK2 mutation. Let's move on to the possible complications of primary myelofibrosis. Sara, why don't you walk us through the most common ones?
Sure. Some important complications include severe cytopenias, which leads to recurrent infections and bleeding, portal hypertension from splenomegaly and liver involvement, and finally, transformation to acute leukemia, as we mentioned earlier, in a proportion of patients.
So, the course of this disease can be pretty serious, especially as cytopenias worsen. Now that we know the pathology, clinical features, diagnosis, and complications of primary myelofibrosis, the last thing we need to know is how to treat it.
Sure. Treatment here depends on age and overall condition. For the first time in this episode, we'll be introducing allogeneic stem cell transplant, and this will be usually used with younger, fit patients. This can be curative, but in older patients or those that are not suitable for transplant, the focus is on symptom control. Here, we'll use drugs that target JAK pathway to help reduce spleen size and improve symptoms, or transfusions for anemia. Finally, we'll offer supportive care for infections and bleeding. The aim is to improve quality of life and control complications.
So, there's a curative option with transplants, but many patients receive mainly supportive care, like blood transfusions and targeted therapies like JAK inhibitors. Do you think our listeners are ready for another question?
A patient has pancytopenia, a very large spleen, teardrop cells on blood film, a dry tap on aspirate, and marrow biopsy shows fibrosis. What is the most likely diagnosis?
If your answer was primary myelofibrosis, you're right. Let's quickly go through why that's the correct answer. Since the bone marrow becomes fibrotic, it can't produce enough cells, so you'll see pancytopenia. There are still some cells being produced in the bone marrow, though, but as they try to squeeze their way past the fibrotic tissue, they become teardrop shaped. And because the bone marrow isn't making enough cells, the body shifts production to the spleen, which causes splenomegaly.
Incredible.
All right, now that we've covered primary myelofibrosis, let's move on to our last topic, essential thrombocythemia. Let's start off with the pathology behind this condition.
For sure. Essential thrombocythemia is a clonal myeloproliferative disorder, once again, that is characterized by a sustained increase in platelet count due to megakaryotic proliferation. The platelets are increased in number and functionally abnormal, which leads to both thrombosis and bleeding.
So in CML, there are too many white blood cells. In PV, there are too many red blood cells. And in essential thrombocythemia, there are too many platelets. Now that we know what's happening at the cellular level in ET, let's talk about how we can actually diagnose it. Sara, can you walk us through the diagnostic tests?
Yeah. So for diagnosis, we're going to have four main modalities. They're going to be CBC, bone marrow examination, molecular tests, and exclusion of secondary causes. First, for the CBC, we'll see a very high platelet count, often at or above a count of 450,000 per microliter. Second, we have the bone marrow examination. Here we'll see an increased number of enlarged megakaryocytes. Third is the molecular tests, where we'll frequently detect mutations in JAK2 and sometimes even CALR or MPL. Fourth is that we must exclude secondary causes. We must rule out things like thrombocytosis from infection, inflammation, iron deficiency, or other underlying disorders. Some of these disorders are the ones we mentioned earlier, like myeloid malignancy under CML or Polycythemia Vera. Only when those secondary causes are excluded and we have persistent thrombocytosis with the clonal markers can we confirm essential thrombocythemia.
Got it. So, the characteristic diagnostic picture for ET is a very high platelet count, megakaryocyte proliferation, a driver mutation, and no obvious secondary causes. Now let's take a step back and look at the signs and symptoms that would make us think of essential thrombocythemia as one of our differentials.
Sure, let's talk clinical features. Today I have three for you. The first is thrombotic events such as deep vein thrombosis, stroke, or microvascular occlusion. Second is bleeding. Despite the high platelet count, the platelets might not function normally. And third, microvascular symptoms like headache, dizziness, visual disturbances, or burning pain and redness in the extremities. Some patients are picked up incidentally when a routine CBC shows a very high platelet count.
To sum it up, a patient with essential thrombocythemia might have clots, unexpected bleeding, and other nonspecific symptoms like headaches and dizziness. Okay, we know what essential thrombocythemia is, how to diagnose it, and what a typical clinical presentation would look like. Now let's go over the treatments.
We'll be discussing two types of treatments, the first being aspirin for microvascular symptoms, and the second is cytoreductive therapy. For high-risk patients, drugs like hydroxyurea, which we mentioned earlier already, can reduce the platelet count. Additionally, another agent called enegrolide can be administered, which will target the megakaryocytes specifically. The exact choice depends on age, previous thrombosis, and overall risk profile.
That makes sense. Since we have too many platelets, we want to focus on preventing thrombotic events. So we give aspirin to prevent platelet aggregation, hydroxyurea to reduce platelet counts, and enegrolide to reduce the number of megakaryocytes. Let's end off our discussion on essential thrombocythemia by discussing the complications of this condition.
For sure, the two important ones are thrombotic complications and bleeding episodes. And once again, over time, a risk of progression to myelofibrosis or acute leukemia is present.
Okay, so we have four complications to remember: clotting because there are too many platelets, bleeding because the platelets can be dysfunctional, and the progression to myelofibrosis or acute leukemia. And with that, we wrap up our discussion on essential thrombocythemia. Let's see how well you all have been paying attention. Here's our last quiz question.
Okay, here it goes. A patient presents to his local clinic for a routine medical checkup. Incidentally, the patient's blood tests reveal a very high platelet count. The doctor decides to conduct a bone marrow examination, which shows many enlarged megakaryocytes. What treatment would you give to manage this condition?
Okay, so we have high platelets and enlarged megakaryocytes. That sounds like essential thrombocythemia. One of the most common complications of ET is thrombosis, so I'd give aspirin to prevent platelet aggregation, and hydroxyurea to reduce the number of platelets, and enegluride to get rid of the megakaryocytes.
You're on fire.
Let's wrap up by summarizing everything in one place.
Good thinking. Here's the big picture. First, myeloproliferative disorders are clonal stem cell disorders with overproduction of mature myeloid cells. The first question that we must ask is about the BCR-ABL gene presence. If it's positive, think chronic myeloid leukemia, driven by the BCR-ABL fusion. If it's negative, think about the JAK2-CALR-MPL group, Polycythemia Vera, primary myelofibrosis, and essential thrombocythemia. Now, for CML, we'll have high white cells and splenomegaly, and it's diagnosed through CBC, cytogenetics, and molecular tests. We treat it mainly using tyrosine kinase inhibitors, and we monitor it using hematologic, cytogenetic, and molecular tests. Now, for Polycythemia Vera, it's a primary increase in red blood cells, often with a JAK2 mutation. It's present with plethoric appearance, pruritus or itchiness after bathing, splenomegaly, and risk of thrombosis. It's managed with phlebotomy, aspirin, and cytoreductive or targeted therapy. Then, for primary myelofibrosis, we'll have the fibrosis of the marrow with teardrop cells and massive splenomegaly. It'll often give a dry tap on aspirate and requires biopsy for diagnosis, and it's treated with a transplant in selected patients and supportive or targeted therapies in others. Finally, for essential thrombocythemia, we'll have marked thrombocytosis due to clonal megakaryocyte proliferation. It'll cause both thrombosis and bleeding, and it's managed with aspirin and cytoreductive therapies, according to risk.
Once you look at them side by side, they stop feeling like four completely different monsters and start looking like variations on a single theme, a stem cell that got the wrong signal and decided to overproduce one particular cell line.
Exactly, and if you remember which mutation is associated with which pattern of overproduction, a lot of the details will fall into place.
That's it for today's episode of PodBites. Thank you for listening, and thank you, Sara, for walking us through this. Make sure to follow PodBites for more short, high-yield episodes where we turn intimidating topics into something you can actually enjoy listening to, inshallah. Until next time, stay curious, take care of yourselves,
And don't ever stop dabbing on them. Thanks, guys.